Well, I've been listening to the conversation to date, and I thought about the old tale of people trying to describe an elephant. So I think program science is a bunch of people trying to describe the elephant. So epidemiologists say there are approximately 26,000 elephants. Most of them are adults, not many youngsters, and they live in India and Africa for the most part. A zoologist says they weigh a lot. Geography, they're in jungles, savannas, zoos, and circuses. Social science, they have social structures, they have families which are matriarchal in nature. Archival, there are a lot of elephant bones. They've been around a long time. Political social science, they can be trained to assist Canadian mining companies. Economists, they're involved in the ivory trade as the origin of this commodity. And program scientists finally come up with the life and times of Babar. Is there a problem? So I think I was invited here because I was thought to be the chief medical officer of health of Nunavut. At least that's how I was addressed in my initial letter. I tried to say that I'm not that anymore. I'm glad that you raised the question about socioeconomic determinants of health, because as we do our work in public health, it's always on my mind that that's an area that we don't tackle. And public health people who try to tackle that generally don't get very far. And one of my good friends who tried to tackle that was fired as a result of it. So we're very constrained, and I think it's a very sad situation. So I'm talking about the challenges and contextual issues with implementation, research, policy, and frontline perspectives. And this is regarding First Nations in British Columbia, but I was in Nunavut before that, and prior to that I lived and worked with the Niska First Nation in British Columbia, and I think some of the areas I'm going to talk about could be generalized to all of those communities. Well, as most of you know who are from Canada, we've got jurisdictional issues. We have programs which are initiated by some people in Ottawa who work for Health Canada. They decide that there is a really good initiative that they think should benefit First Nations people, and they send the word out all across the country. This is what we're going to do. For example, this is what we'll do with HIV, or this is what we'll do with STI programs. At the same time, the province of British Columbia says, we've got our own plan for STI, HIV, and then the Aboriginal community says, we've got our own plans, and many different organizations are involved. And what I've seen in the past 20 years is that there's been no progress in terms of community understanding or a lack of fear of HIV. There's still a lot of stigmatization, and the same messages are still being presented over and over and over to First Nations communities, and they have not had an impact. So I think that's a very interesting challenge for us to look at, how come all the efforts of public health in 20 years have not changed perceptions in many First Nations communities? Okay, data linkages and frontline access. Well, I'm the Director of Health Protection for the First Nations Health Authority. So responsible for TB program, immunization program, HIV, AIDS, STI, BBI, and guess what? I don't have any data to work with. There aren't identifiers in the most case, in most jurisdictions, that will identify First Nations persons, or if there are, they're closely guarded. There's controversy over who should own the data, with the OCAP principles being forwarded by the First Nations community recently. So this is a case in a lot of federal and local programs. So if you don't have data, how can you really know what the problem is? And that's something that we face all the time in working in First Nations communities. Funding envelopes. Who's going to fund what? Well, the federal government, as I said, may fund part of an initiative or may fund the whole thing. Provincial government may fund it. So we have different players with different ideas about what's needed which doesn't allow for much program science. I mean, the players don't even know who they are, don't even know who the other ones are. And we have program and policy silos. When I worked in Nunavut, we were at least able to work with the public health agency to do some research in terms of the prevalence of HTLV1 there. And also we worked on the prevalence of human papilloma virus, what kind of types are in the Inuit population. So we managed to combine science and our programs. We had to couch them in different terms so we didn't have to go through too many ethics reviews. I don't know how many of you have had programs either derailed or delayed significantly by ethical reviews. You know, it would be nice if the government had such a review. There's not much in the way of community-based evaluations and research. I mean, we talk about programs starting in partnership with the communities. If you don't start that way, you may get a very poor result. But it's very rarely that communities come up with a description of their need that then we try to work on. Operational research, we've got no operational research. Before the First Nations Health Authority, the position that I was in was with First Nations Inuit Health Branch, and I remember that about 20 years ago, Ian Potter said, how do we know whether our programs are working? We don't have any data. We throw millions of dollars at these programs. We never know if they're doing any good. And that's still the case. But operational research, how do we know how our implementation is actually being carried out? Is it effective? We don't do that. We don't have funding for it. Nobody thinks about it. So a bureaucratic way of looking at a problem is, at least the bureaucrats that I've worked with, is it's a big problem. Here's some money, hope it works. So I'm ashamed, actually, to be up here today after listening to our first group of speakers who are so eloquent and have accomplished so much. In terms of First Nations health in Canada, I think we haven't accomplished that much. Frontline access to scientific evidence. I've been amazed at how little science enters into public health decision-making in Canada. And in fact, when I sat on the Public Health Network Council, all of the decisions are ultimately made by deputy ministers of health, regardless of the evidence that's brought to them by public health experts. And public health experts are very much constrained because they report to governments. And I think it's a huge problem in Canada. Chief medical officers of health are meant to be independent. They're meant to be able to criticize their government. None of them does that. They can't criticize their own government, and their own government says to them, if they work for provinces or territories, don't criticize the federal government because they give us a lot of their money. So we're in a very limited environment in terms of really taking on the big challenges. Project timelines. In First Nations communities, it takes a long time to actually become a trusted person in the community. And I've only heard of one area, one project in which the researchers are going to be placed in the community for a number of months before they even start talking about what the project's going to be. And with the history of colonialism and racism and medical interventions, which were not necessarily in the best interests of First Nations people, that is a big problem. I don't know if you find that in Africa. I don't know if there's the same legacy of, medicine. There's a book called Colonizing Bodies by Mary Ellen Kelm, and I'd advise you to read that if you can ever find it. It tells about the history of federal government's health plans for First Nations people. And coordination of implementation of funding cycles. Well, here's something interesting. We'll have a program that we want to introduce, and it gets accepted, and then the government funding comes about 6 months into what we thought was going to be the operational phase of the program. So by the time we've got it started, the funding cycle's over. And this happens again and again and again. And limited value for money evaluations. Yeah, we have things like, we got reports of nurses. We saw 237 children with otitis media last month. What's the denominator? We don't know. Was it one child coming in with 237 ear infections or 237 coming in with one? We have no idea. So very limited. That is a somewhat realistic view of where we are working in health with First Nations communities. I must say also, before I end, British Columbia puts out stats on HIV/AIDS, and of course the Indigenous people, First Nations, are disproportionately represented, and so First Nations people are considered at greater risk. But we don't tease out poverty, homelessness, violence, and if we tease those out, what is the risk of being Aboriginal versus being anybody else? Thank you.